For years, the path for severe glaucoma was clear, often leading to invasive surgery. But what if a less invasive approach could rewrite that narrative? Dr. Shamil Patel, a pioneer in canaloplasty, presents compelling evidence that could reshape how we treat advanced glaucoma.
I've been doing canaloplasty externally. I started probably in 2010, and then they developed the interno approach a few years later. And since then, it's my primary MIGS treatment for all patients across the entire spectrum of the disease. So I think in our data over the past 5 years, I think I've done about 2,100 cases.
Glaucoma severity is key, typically classified using the Hodapp-Parrish-Anderson criteria, based on mean deviation of visual field loss into mild, moderate, or severe stages. But applying MIGS to severe glaucoma was historically met with skepticism.
There was a lot of concern about the efficacy. I think there was a thought process that once the patient had already progressed to the severe level of disease, angle-based surgeries wouldn't have the potential to bring the pressure down to the level that was required for that stage of disease. With the severe patients, the goal is always to bring the pressure down as low as possible. And typically MIGS surgeries, the floor is usually between 14 and 15, and some of these severe patients need much lower pressures. So the concern was that MIGS would not be able to achieve such a pressure reduction for those patients.
Dr. Patel's study investigated ab-internal canaloplasty's long-term impact. This retrospective series reviewed 72 eyes over 3 years. The patient cohort represented the full spectrum of primary open-angle glaucoma. Approximately 1/3 of eyes had severe glaucoma, while the remaining 2/3 had mild to moderate conditions. The study compared outcomes by glaucoma severity and also by baseline IOP control. This involved categorizing eyes as controlled, with a baseline IOP at or below 18 millimeters of mercury, or uncontrolled, with an IOP above 18 millimeters of mercury. Key endpoints were the reduction in intraocular pressure and the number of glaucoma medications required.
For the entire group across all stages, controlled or uncontrolled, the average starting pressure was in the mid-18 range, around 18.5, and we achieved nearly 5-point pressure reduction to the mid-13s, which was about a 25% reduction in pressure. The medication burden reduction was about 29% across the entire population.
So how did canaloplasty perform across disease stages? Comparing mild to moderate with severe glaucoma, both groups showed strong IOP reduction, 28% in mild-moderate and 23% in severe cases. Critically, over half in both groups achieved more than 20% IOP reduction. Medication dependence also fell dramatically by 40% in the mild-moderate group and by 18% in severe cases.
For our severe glaucoma patients, canaloplasty is the only treatment that can treat the entire outflow system comprehensively. So being able to pressurize the entire system allows us to restore the function and the outflow in patients that otherwise may have had atrophied systems. The more limited MIGS only work on the first or second layer of the drainage system, whereas we're able to work on the entire system.
And what about baseline IOP control? In controlled eyes, IOP still fell by 21%, with an impressive 36% medication reduction. Uncontrolled eyes saw a more pronounced 32% IOP drop and a 27% medication decrease.
In our control patients who already have reasonable pressures, we are able to reduce the diurnal fluctuations that definitely cause damage in the disease. And then we're also able to reduce their medication burden. And we're learning about a lot of the side effects and what that does to the ocular surface and the patient's quality of life with these extra medications. So reducing medication burden for these patients is a very valuable thing for their long-term care. For our uncontrolled patients, reduction of the pressure allows them to have vision preservation over time.
So what is it about canaloplasty itself and the technology used that contributes to these outcomes?
The uniqueness of canaloplasty is it's the only surgery that's trying to restore the physiologic outflow of the system and able to fully pressurize and viscodilate the entire outflow. I think the most important takeaway from this study is that canaloplasty is effective on the entire spectrum of disease. So we're able to utilize and try to tap into potential of the entire outflow system prior to doing something that may actually send fluid to an outside space. So in canaloplasty, we're trying to do exactly what evolution intended. In the other surgeries, we're really trying to change things. We're really sending fluid to places where it's not supposed to be. So this is kind of the most physiologic and beautiful surgery we do for glaucoma.